The end of the last section, I was talking about how there's a lot of processing that goes on in the spinal cord, particularly motor processing. And then we're going to tiptoe past the spinal motor coordination section in the book. We're not going to talk about it. We're just going to say it's complicated and go on to spinal cord lesions. So we're going to talk about some spinal region syndromes and which body functions are lost or spared. A lot of times students are confused on like, what do you mean by lost or spared? So if you don't lose a function, then it's spared. So you might lose conscious proprioception and light touch, but you're spared motor function or something like that. So we're also going to list the red flags for a cauda equina lesion. Cauda equina is one of the 5 spinal region syndromes. We're going to talk about segmental versus vertical tract lesions in the spinal cord. So a lesion in the spinal region can interfere with segmental function, vertical tract function, or both. And the signs of it and the effects of it are going to allow us to know whether it's a peripheral injury, a segmental injury, or a vertical tract injury. You could have both segmental and vertical tract function affected just to make it interesting, because nothing's not complicated, right? So the signs of segmental dysfunction are segmental signs at the level of the spinal cord that's affected. So the segmental signs include abnormal or lost sensation in a dermatomal distribution or motor neuron signs in a myotomal distribution. So if it's a dermatomal or myotomal distribution, it is a sign of segmental dysfunction. So we talked about in the peripheral system, dermatome, throughout we've talked about a dermatome is the cutaneous area that's innervated by a single spinal segment. The myotome is the muscles that are innervated by a single spinal segment. So if you have signs in a dermatomal or myotomal distribution, that is a sign of segmental function. If you have them in a peripheral nerve distribution, that's a sign of peripheral dysfunction. A lesion of the ventral horn, ventral root, or spinal nerve interferes with motor neuron function. Okay. And if it's the dorsal horn, of course, it's going to interfere with sensory function. Vertical tract lesions result in loss of communication to or from the spinal levels below the lesion. So ascending tract signs include problems with regulation of blood pressure, sweating, and bladder and bowel control. So it's affecting the vertical autonomic tracts. Descending tract signs include paralysis, spasticity, and muscle hypertonia. If the lateral corticospinal tract is interrupted, then Babinski's sign is present. So Babinski's sign is a reflex test where you sort of scrape your thumb along the bottom of the sole of the foot, and a positive Babinski sign, the toes splay out. In babies who haven't integrated that reflex yet, they have a positive Babinski. Normal adults do not. They have a negative Babinski. So adults with vertical tract dysfunction show that Babinski sign. All signs of damage to vertical tracts occur below the level of the lesion. So you can have spinal region lesions that cause both segmental and vertical tract signs. This is the example from the book. A lesion at the C5 level on the right that involves the right dorsal quadrant of the spinal cord, right dorsal quadrant of the spinal cord. So dorsal, it's going to prevent light touch and conscious proprioception from the right side, because light touch and conscious proprioception run in the dorsal column. Remember that. And you're not going to get that information from below C5. So that's the vertical. So there you have segmental and vertical. The lateral corticospinal tract from the right side of the body below C5 and sensory information from the C5 dermatome and myotome would also be lost. So we're getting a segmental injury that has vertical tract effects as well. So in order to differentiate peripheral region lesions from spinal region lesions. Peripheral region lesions produce deficits in the distribution of a peripheral nerve. So like in the median nerve distribution or the sciatic nerve distribution. So you get altered or lost sensation in a peripheral nerve distribution rather than dermatomal or myotomal. Decrease or loss of muscle power in a peripheral nerve distribution is also a peripheral lesion, a sign of a peripheral lesion. No vertical tract sign, so there's no loss below the level of the lesion. And decrease or lost phasic stretch reflex, which is actually in both peripheral and segmental spinal lesions. So spinal region segmental signs occur when nerve roots or spinal nerve roots are compromised. So if, say you had stenosis of the intervertebral foramina, that could cause a spinal nerve to be compromised. Segmental signs are altered or lost sensations in a dermatome or decreased or lost muscle power in a myotome versus peripheral nerve distribution, and also loss of the stretch reflex, but that's in both, so it's not a differentiating sign. Vertical tract signs include altered or lost sensation below the level of the lesion. Altered or lost descending control of blood pressure, pelvic viscera, and thermoregulation. That's the autonomic part of it. Motor tract signs include decrease or loss of muscle power, spasticity, muscle hypertonia, and if the lateral corticospinal tract is involved, a positive Babinski sign and clonus. So those are all motor tract signs, and they occur below the level of the lesion. Okay. So spinal region syndrome. So this is the diagram from the book, and it is really small here, but the dark part on the cross section of the spinal cord is showing basically what part of the spinal cord is affected. So in the top one, the anterior 2/3 of the cord are affected. So we have to think about what's in the anterior 2/3 of the cord to know what the effects are going to be, and we'll talk about it. In letter B, the top right, the middle part of the cord is affected. In letter C, the bottom left, it's a hemisection of the cord. So 1/2 of the cord is affected. And in letter D, that's called Equine syndrome. So it's not actually the cord itself, it's the nerve roots, the axons down at the bottom of the cord. And so we get some different symptoms with that. We'll talk about each one of the syndromes. So anterior cord syndrome is typically caused by a disruption of blood flow in the anterior spinal artery. So if you recall, I briefly said that the anterior spinal artery serves the anterior 2/3 of the spinal cord. And so ischemia from disruption of the blood flow in that artery damages the anterior 2/3 of the spinal cord. So it affects ascending spinothalamic tracts and descending upper motor neurons. So ascending spinothalamic tracts are giving us pain and temperature sensation, and the descending motor tracts give us motor control. So we lose those in anterior cord. The thing we keep, what's spared, is we still have the dorsal column, so we still have conscious proprioception and light touch information. So those functions are spared because they're in the posterior or dorsal part of the cord. So with central cord syndrome, it's a small lesion right in the center of the cord, usually occurs at the cervical level as a result of trauma or occasionally infection that causes inflammation. If the lesion is small, you might lose some nociceptive and temperature information at the level of the lesion, because that's where the spinal thalamic tract crosses over, and that it gets interrupted. Larger lesions can impair upper limb motor function because the medial area that's affected, the upper limb fibers in the lateral corticospinal tracts. So central cord syndrome is usually a loss of pain and temperature at the level of the lesion. So that's the segmental effect. And then upper limb motor function, that's the vertical effect in central cord syndrome. So you get both in central cord syndrome. In Brown-Séquard syndrome, it's a hemisection of the cord. So half the cord is functioning and half of it isn't, which kind of makes it interesting. So usually Brown Séquard happens because of some kind of trauma, like a car accident or a stab wound or a gunshot wound or something that affects half the cord and doesn't affect the other half of the cord. So segmental losses are ipsilateral, meaning on the same side as the damage, same side as the lesion. And so ipsilaterally, you lose motor neurons and all sensations on the same side. On the opposite side, you lose nociception and temperature sensation because of where the spinothalamic tract crosses over. So, kind of interesting. So you have basically you have motor control on one side and you don't on the other, and you have some sensation on one side and you don't on the other. So it's a pretty interesting. Unless you work in a specialized neuro rehab place, you are probably not going to see Brown-Séquard syndrome. I've been lucky enough to see a couple people with Brown-Séquard in my lifetime, so in my career. Cauda-Equina syndrome causes sensory impairment and flaccid paresis or paralysis of the lower limb muscles, bladder, and bowel. So a lot of times it's because of damage to the lumbar or sacral spinal roots. And you don't get spasticity and hyperreflexia because the cauda-equina is below the spinal cord itself. It's the nerve roots coming off the spinal cord. So the upper motor neurons are still intact. And complete cauda-equina lesions are rare. Usually it's partial. So you get some weird symptoms. And a lot of times people have bilateral sciatica going down both sides of their legs as well, and that's usually the thing they end up getting referred to PT for. And then as we're screening them in the initial evaluation, we go, oh, wait a minute, bowel and bladder issues. Something's going on, and sensory impairment. So usually cauda-equina syndrome is treated medically, but you got to know you have it in order to treat it medically. And I've worked with people with cauda-equina that have had full recovery, which is great. So tethered cord syndrome is basically during development, the vertebral column grows longer than the spinal cord. And sometimes, I mean, that's normal that the vertebral column grows longer than the spinal cord, but sometimes, not very frequently, the spinal cord becomes attached to the surrounding structures during early development. So you get scar tissue or abnormal development that leads to tethering of the spinal cord. So as the vertebral column elongates as the child develops, the tethered spinal cord becomes stretched. So the stretch injury damages the spinal cord and sometimes the cauda-equina. And so usually the signs are lower limb pain, low back pain, difficulty walking, excessive lordosis. That makes sense if you've got stretching on the spinal cord. Scoliosis, sometimes problems with bowel and bladder control, and sometimes foot deformities. So lower motor neuron signs, so weakness and flaccidity, hypotonia occur if the anterior cauda-equina is stretched. Upper motor neuron signs, so abnormal reflexes, hyperreflexia, paresthesias, and hypertonia occur if the spinal cord is excessively stretched. So a lot of times abnormal signs on the lower back indicate tethered cord associated with spina bifida occulta. So it's interesting. You might have like a lipoma or a tuft of hair or a hemangioma, which is the tangle of blood vessels, or a little fatty mass there. So tethered cord is like a less common version of spina bifida. In severe cases, they might have to do surgery to untether the cord. So the symptoms commonly appear during a growth spurt when the spine suddenly grows a lot, and then you get stretching on the spinal cord. Interesting, right? So Spinal region dysfunction affects pelvic organ function and sexual function, or it can, depending on the level of the cord damage. And we'll talk a little bit more about that in the next section. But the effects of spinal cord lesions on bowel control and sexual organ function is similar to the effect of spinal cord injury on bladder function, which we'll talk about in the next section. And sexual function is a significant issue for many people following spinal cord injury. So we're going to talk a little bit about the effects of spinal injury and the symptoms associated with spinal cord injury, but then the treatment for spinal cord injury, which is covered in the book, you're going to cover that next quarter in your neuro rehab class.